Aloha, everyone. And so we're going to be presenting some preliminary findings from the Maui Wildfire Exposure Study. We believe that our findings are not just research data points, but actually crucial insights for both individuals and policymakers that they need to make decisions. But before we dive into the study, I think it's important to recognize a critical reality of disasters. So when people are struggling with housing, jobs, and food security, understandably, health is often not an immediate priority. And this is a serious issue with long-lasting consequences, as we have seen from other disasters. And this underscores the importance of early monitoring and proactive intervention, which is what the study is trying to do. To give you an idea of the disaster, over 100 individuals actually died from the disaster. This is the worst natural disaster in the state of Hawaii and the deadliest fire in the US in over a century. And unfortunately, I mean, this disaster is disproportionately impacting those who need it the most, especially those suffering from health disparities. And this includes really diverse communities in the state that are not only, Native Hawaiian, Pacific Islanders, but we also have a large proportion of Filipinos, Hispanics in this case, and other Asians individuals. One of the key approaches that Alika and I have been using, and it's, I would say, like our secret recipe, is that, and we've been doing this in many cohorts, is blending research with health education and direct services for participants. So we not only gather data, but we actually provide participants with immediate health support, ensuring that they receive the help that they need, right away. And this type of academic community partnership is something that we have been doing in the past in over a dozen cohorts. And we believe it's a reason for the success on the recruitment of the cohorts. Some are depicted here with over 50,000 participants. That includes, a large COVID cohort, the UHERO Rapid Survey, which is collecting data on every 6 months from individuals across the state of Hawaii, and a diabetes cohort of 2,100 individuals, among others. Maui West is a grassroots effort initiated by those directly impacted by the fires and supported by several multidisciplinary units at the University of Hawaii. We've assembled a community advisory board to guide the study findings based on local needs. We also have a scientific advisory board to evaluate long-term health impacts, ensuring that we provide medically relevant screenings. And we need that trust is an issue. So we got support from, a variety of community partners working with survivors. This includes, Maui Medics, Hilar Hui, Roots Reborn, Taknawa for Maui, had been on the ground, and this allows us to launch the study as quickly as we can, about 6 months, less than 6 months since the disaster happened. But this is a truly academic community partnership built from the ground up, reflecting our commitment to addressing the needs of the community affected. And in terms of funding, this is one of the projects that we just couldn't wait, 9 to 12 months to get funded from NIH after the disaster. And we literally had to start without any funding, often using, a little bit of money that we had here or there. And luckily received charitable donations from a couple of community organizations in Hawaii to get us to fund the cohort for the collection of samples of participants, and later NIH and the state of Hawaii came in. Some of the goals of the study are depicted here, but primarily is to establish a cohort of 2,000 individuals impacted by the fires to evaluate the short and long-term health outcomes. We started data collection, as I mentioned, as soon as we could, and expected to continue collecting this information for the next 5 years, as what the funding that we have from NIH. And based on observations from other disasters, like the World Trade Center Registry, we're hoping to continue, for the next 10 up to 20 years. So based on need. So we have, so the goal is to collect 2,000 individuals impacted by the fires, and the data gathering started January 26, 2024. Alika.
Some of the data elements that we included in the study are listed here. You'll see that we asked in the questionnaire format about demographics, housing stability, food security, employment status, exposure, also resiliency, social support, health behaviors, and trust, and amongst other components. We also collect biospecimens to understand stress response, inflammation, and exposures to potential environmental toxins during and after the aftermath of the fires. And so we collect urine samples, saliva samples, buccal swabs, as well as blood samples. We also provide a health screening, and I'll mention it here, where we check in participants into the study after going through the questionnaire, after going through the consent form and signing off. They get their questionnaire, finish that questionnaire, and they get a kit. And we take them into our stations, and they go through a cycle through the stations where we collect samples, their urine sample, as well as collect blood samples in the next station, and also perform point of care testing on their blood samples for looking at any potential chemistry that could alert some medical emergencies, such as heart disease. We also collect saliva samples, buccal swabs, measure height and weight, blood pressure, and spirometry readings to measure lung health capacity. And then we collect the results of those screenings immediately after the cycle, and provide individuals with information about their immediate results, as well as provide them with a consultation about those results. And it's usually a nurse practitioner or an internist that would help read out the results. We have PCPs and other physicians that will help us on site as a volunteer effort so far to provide some of that consultation on the spot, and information is delivered immediately. We also provide information in an electronic format on their data dashboard portal. Rubén, can you advance the slides?
Yep.
This is just one example of the participant result sheet that they get during the screening itself. And as you can see, we record the blood pressure of the day, provide the spirometry results, some of the blood test results as well, that they can use for their provider. And we provide also links and information to resources, community-based resources that we know about that would help them further to navigate healthcare, especially some of the insurances that they may have lost during the fires. So can you go next? So this is a pretty diverse cohort. We were lucky to recruit initially. I think it's really the effort of our partnerships with our community-based organizations that provided accessibility, language, as well as cultural activities that would help to engage participants in the study. And so it represents a pretty diverse community that were affected by the fires in Lahaina and Kula. This includes Native Hawaiians and Pacific Islanders at 20% of our cohort, white population at 30%, Filipinos around 20%, and Hispanic and Latino 18%, and non-Filipino Asian population at 11%. So it's one of the most diverse, ethnically diverse cohort to date, and especially, I think, the most comprehensive cohort to follow short and long-term health consequences after a disaster in Hawaii. We also get pretty good representation by age. Can you go back quickly? About 30, the average, about 64% of the cohort comprises individuals, the working age about 35 to 64 years old, and almost equally split between males and females. So to date, we've recruited more than 1,200 participants into the cohort, so far adults, and we're now expanding it to children. Continue. We also have broad representation by residences affected by the fires included in the cohort. And these are just two maps of the Lahaina town area on the left-hand side and Kula on the right. And what you'll find is that these little dots represent geocoded residential addresses of individual participants in our cohort. And you'll see in Lahaina on the left, for example, pretty widespread distribution over the town that have been affected by the fires, and as well as in Kula, which is a more mountainous region alongside hills and cliffs, that you'll see some more scattering of some of the participants there. Next, please. Another way that we disseminate data to participants is through their data dashboard and portal. So we provide the rapid results immediately in that paper form that they get after the health screen, and then we also provide them an electronic copy of that information along with every other data that's included from that day, as well as when we collect information about potential environmental hazard exposures, we'll provide that data back to participants in the form of this data portal that they can securely log in individually to. And they also get access to aggregated data from the cohort study in the form of a data dashboard. And this is what we released in a few months ago, so that you can check it out as well. It's public facing. And you can see how some of the demographics break down with some of the information that we've collected from participants, such as potential exposures, health conditions, including mental health and other information there. So the participants can not only get their individual data, but they can see where they are in their cohort. Continue. Oh, and then another thing we should mention briefly is that the data dashboard is also another avenue for them to learn more about connections to specific care that they may need, insurance, health insurance, or other health services, community-based organizations that run programs that may have benefits for them, either mental or physical health benefits. They'll have that link to all of those resources, and so they can navigate that through their portal. All right.
Yeah.
Rubén?
And in May of this year, so we released a report of some of the main findings. It's available for you to take a look online on our website, mauiwest.org. But basically, the main trends that we were able to find from the first 750 individuals in the cohort is that there were pretty concerning mental and physical health issues, access to care as one of the main barriers, and housing, job, and food insecurity issues. And I'm going to go really quick over these results, but basically, we're finding some alarming rates of mental health issues among survivors. To give you an idea, pre-wildfire, we actually had a cohort that's been running that allows to do a comparison to this cohort statewide. We're seeing that restricted to the Maui residents, about 30% of individuals were showing depressive symptoms. Post-wildfire, we're seeing about 52% of individuals, right, in our cohort. So it's an increase of more than 20%. There is also larger levels of low self-esteem. 19% of the cohort reported low self-esteem, and 30% had moderate to severe anxiety. Another of the issues is suicidal ideation. 4.4% had considered suicide over the past month. And when you compare that with about 1% suicidal ideation pre-wildfire, I mean, that's a huge increase, of course. Nearly half of the participants reported worsened health since the fires, particularly among those with high exposure to wildfire ash, debris, and smoke. And this is one of the concerns that really motivate us to do the study, right? I mean, that we knew that there was going to be this need, unrecognized need, right, to address these health issues. The type of symptoms that participants reported to us include coughing, wheezing, difficulty breathing, skin and eye irritation, fatigue, and weakness. And then another of the things that we saw is that those participants who self-report with larger self-reported exposure to the contaminants, right, to the ash, debris, etc., are actually self-reporting higher symptoms as well. So this association is something that definitely was concerning whenever we started analyzing this data. So in particular, right, individuals who reported frequent exposure to wildfire debris, smoke, and ash tended to experience these more symptoms. There was a high prevalence of cardiopulmonary risk. About 70% of participants face a heightened risk of cardiovascular disease due to high blood pressure at elevated hypertension levels. So up to 60% of participants also suffer from poor lung health based on the spirometry that we perform on site, with up to 40% of individuals with mild to severe lung obstruction. On the social aspect, over 70% of participants reported loss of income after the fires. So this is obviously something that we were expecting because obviously, things burn, right? I mean, employment in particular. So the hotels were shut down. Many of these employees actually work at hotels. But this social aspect actually is connected, obviously, to health of individuals. Another of the social aspect was the increased difficulty in accessing medical care. So 4 in 10 participants in the cohort reported having trouble getting medical care or medications, compared to 1 in 10 before the fires. And of course, like, individuals below the poverty line are the ones who actually were suffering the most, right, from this increased difficulty of getting medical care. In particular, right, so to give you an example with health insurance, so Hawaii is a state where, like, almost everyone has health insurance, especially working age population. So pre-wildfires, we anticipated about 5% of individuals didn't have health insurance. Post-wildfire, for the Maui West cohort, we had 13% of individuals that didn't have insurance. And what was particularly concerning is for the Hispanic and Latino population, where 38% of individuals of Hispanic, Latino origin didn't have health insurance. And these are individuals who they had insurance before, but they lost it due to they lost employment, basically, and they don't qualify for many of the social services that are available. Another of the issues is the increased food insecurity. Almost half of the respondents experience very low or low food security, and this is significantly higher than the pre-fire UHERO rapid survey for Maui residents, where less than a quarter of participants were found food insecure. So it's almost double, basically, the participants. Not everything is bad news, right? On a positive note, resiliency is on the top mind for many participants of the study. So we are observing 2 positive trends. The first one is that, lower income individuals who, arguably are the ones who need this the most, trust and use community organizations more than government services, especially from federal, state, and county agencies. And this trust is really, really important, right? And it could potentially could be an avenue for us to intervene to provide those services to participants. The second trend is that people who maintain strong relationships with family and friends experience better health outcomes. And in this graph, so we are seeing that participants reporting high levels of perceived social support tend to have less depressive symptoms than those reporting low levels of perceived social support. So again, that's a potential avenue to intervene, right? To make sure that we connect those participants more effectively.
We're starting to understand the impacts of potential exposures on the health outcomes of individuals affected by the fires. One way to do that is to look at the degree to which they might have been exposed to potential fires, smoke, ash, independently of their self-reported information. So we're trying to understand that better. One study that shared some data with us that from satellite imagery of the fires was able to kind of isolate the timing of it and recreate sort of the timing and the how the wildfire spread within the Lahaina town. And this is a graph depiction of that heat map that you can see here, where the fire spread from that green zone in the middle and then outwards to the rest of the heat map. And on top of it is our geocoded residential addresses that we've added into the map and started to use that as a potential proxy for exposures and connect that to some of the health information that we've been collecting from participants. And so again, this is preliminary data, but we did find a pretty significant trend here with looking at proximity to how the wildfire spread, and then within the region, residential areas within the burn zone versus those outside on the periphery. And we found that when we associate some of the regional distribution with health outcomes, in this particular case, the spirometry metrics to look at some of the lung health capacity, we found that individuals that tended to be outside the burn zone, so those in the proximity but away from the immediate burn zone area during the times of the fire, they tended to have better lung capacity from the spirometry reading than those within the fire perimeter itself. And that's suggestive that those individuals that were within the fire perimeter tended to have a higher degree of exposures potentially that then led to these health conditions. So again, we're still trying to understand this more comprehensively and determine whether or not that also relates to some of the other sort of indirect exposures through some of the chemical hazards that they might have been exposed to after the fires, even potentially re-exposed while returning back to those zones for reconstruction and the rebuilding. Next slide, please. One of the other things that we're trying to understand is the degree to which people might have been exposed to the chemicals from the ash and smoke from the fires, again, immediately during the time of the fires, or longer term, such more chronic exposures because of the re-entry into these burn zones for the rebuild. And so we're following participants again annually to look at those exposures and collecting biospecimens to see what the individual level of exposures are. And so in this particular example, again, preliminary data, we've surveyed urine samples from participants and subjected them to mass spectrometry to look at specific elements, in particular heavy metals that might be enriched in the ash from the wildfires. And so back in November of 2023, the Department of Health did a survey and screening analysis for some of the contaminants that might be in the ash from the fires, and they found that arsenic, lead, antimony, cobalt, and copper, these heavy metals, were enriched in the ash, and so potential sources of exposures from the in the aftermath of the fires and potentially re-entry as well. And so we've included those 5 heavy metals in our screening, as well as additional elements, up to 33 different elements, to look at potential exposures to these hazards that might contribute to some of the health conditions. Next slide, please. So this is just, again, preliminary data from half of the participants in the study so far, about 767 adult participants from the urine analysis. And again, we're concentrating on the 5 heavy metals that are implicated from the Department of Health, such as arsenic, lead, antimony, cobalt, and copper, but we also include other heavy metals that the community has been concerned about, including nickel, selenium, and chromium. And so this is just a distribution plot of the concentrations of the heavy metals from the urine samples and the frequency or the density those individuals are exposed. So the red dashes along these plots are the median values for each of these heavy metals, and you can see a broad distribution of concentrations in the cohort itself. So, majority of the individuals fortunately have low levels of these heavy metals from in the urine samples, but up to about 20% of participants do have a high degree of concentrations of these heavy metals in their urine samples. And this was, again, taken from 6 to 9 months after the wildfires, so potentially these heavy metals in the urine samples will have varying degrees of half-lives, but likely that this could mean that individuals might be re-exposed to these heavy metals during the recontact and during the re-entry to the burn zones that remain that is continuing to be cleaned up and cleared for reconstruction. But again, this potentially represents some of the ongoing chronic exposures people might be experiencing. We started to understand this in the context of health and determine whether or not these higher concentrations of heavy metals from the urine samples might be contributing to some of the health outcomes that we're measuring on the spot from participants. So again, going back to lung health, we looked at the association between some of the heavy metal concentrations that we saw in the urine versus the spirometry scores in FEV as well as FEV1, just as an example. And as you can see, high levels of arsenic in this case showed a really strong anti-correlation with FEV1 and FVC outcomes, which is indicative of the poor lung health. So higher degree of arsenic correlates to this lower FEV1 and FVC values. We also did this in multiple ways. If you look at the FEV1 to FVC ratio, we see tended individuals that have higher levels of arsenic exposures tend to have lower scores overall on the spirometry, as well as if you categorize them based off of potential mild to severe lung obstruction off of the FEV1 categories, you can see that individuals, again, with higher levels of arsenic in the urine samples tend to be those that have more severe lung obstruction. So again, going back to understanding how potential exposures might be leading to some of the conditions that we're already screening for, something that we're working on. And then, of course, we're going to be assessing this over time in the same cohort. So we'll be looking at any of the changes in these metrics over time to determine whether there's any causal relationships. Next slide, please. Again, just another way to look at some of the data. This is looking at the different heavy metal concentrations, especially arsenic, but others such as lead, copper, antimony. Again, those that have been implicated in the ash from the fires. And we do see relationships to specific blood biomarkers from the point of care testing that we provided from participants. And so, for example, lactate levels seem to be much higher in a portion of the population than it should be at resting states. And so one of the, we're trying to understand why that might be. And we found some of the interesting data coming out so far suggested that potentially higher levels of arsenic could be contributing to this higher levels of lactate that people are presenting with at the time that we've collected the samples and enrolled participants in the study. So again, we're still trying to understand how that might be associated with some of these health conditions that individuals are presenting with so that we can intervene earlier and inform public policy and practices to help with reducing potential exposures during the recovery process. Another way looking at the data is that we were able to get some information about self-reported frequency of some of the symptoms. And Rubén mentioned already, one of the more frequent symptoms that participants presented with at the time of the study entry was eye and skin irritation. And again, we suspect arsenic could be involved. So if we looked at the concentrations of urine arsenic from participants, we see that individuals with higher levels of urine arsenic tended to have experienced more of these eye and skin irritations and those with lower levels of arsenic in their urine. So potentially contributing again, these heavy metal exposures might be contributing to some of these health outcomes that we're seeing. So another way to look at that data. Next. So we're now starting to expand the study. So from our initial target number was 1,000 adult individuals, and we're able now to expand it with state funding, as well as NIH, fortunately, to scale it to 2,000 participants to include children and first responders and volunteers that are helping with the reentry and the rebuild. That's happening right now. And so again, we're trying to reinforce best practices to limit or reduce potential exposures, but that's often, there's some issues with that as well, especially in Hawaii. So we're working with our community-based organizations and other medical providers to inform participants, as well as those that are going back to rebuild around those best practices, and also encouraging participation among them as well to expand the study. And we've also launched the Maui Registry. So to, again, to inform individuals that might be outside the scope of our cohort about some of our study findings. And, around 10 to 12,000 individuals have been affected by the fires. And so this is one avenue for us to reach out to them, keep track of them, also passively monitor some of the health conditions that might pop up over time in this particular population that's been exposed to the fires, and also make sure that they also are getting information that we provide our cohort. Rubén?
Yeah, so and just to conclude, some of the early lessons from Maui West have highlighted some critical insights into how we can better support our community during disasters. So, one of the first insights is that health often becomes a secondary priority in disasters. So we've seen that basically people who are struggling with housing, jobs, food insecurity often delay their health. And what we are providing here is a way for them to come into the study and get their first health check since the fire. More than half of the participants who are coming over to the study, they never had a health check in their since the wildfires happened. So we're glad that we are able to provide that. So we're tackling this head on, right, with these proactive health screenings. The second thing that I want to highlight is these integrated support strategies for evaluation and monitoring. Yeah. So as we gather data, we're developing these strategies in this near real-time system through the dashboards that you hear of for participants, for community, that has enabled us to tailor some of the interventions and some of the need, get this data to inform policies, especially for vulnerable groups, including low-income households, food insecure families, immigrants, those with pre-existing health conditions, and people with disabilities. And finally, we are enabling long-term and sustainable solutions. So our focus is not on the immediate health concerns after the fire, but really in these long-term health outcomes and a sustainable way to evaluate the health of those individuals, not only of this disaster, but potentially for other disasters. I think that our initiative to partner with community has allowed us to not only address the immediate crisis, but ensuring that these interventions and lessons learned will continue to benefit Hawaii or Hawaii's populations long after these disasters. So these lessons overall remind us that by prioritizing health, leveraging data, fostering partnerships, and planning for the future, we can build a more resilient and a healthier community for all. So thank you for listening to this presentation. And thank you to all our partners, actually.